Good. And there we are. So today, hello, Phil Morris from Testicular Cancer UK. Used to be Checkham Lads, still is Checkham Lads, but new name. Today I'm going to be talking to a wonderful long-term friend of mine, Mick Craycraft from Cincinnati is it Ohio, is it?
Ohio, yes.
Ohio, United States. And he's the founder of the Testicular Cancer Society, which you've probably seen about. And I've known Mike for, I don't know, Mike. It's over 10 years, isn't it? So it's a long time, I think. So I'm going to introduce you, Testicular Cancer UK, to know Mike, who I respect quite a lot, to be honest, because he's a good lad. And we're going to have a quick chat. And so the first question we're going to ask is, Mike, when did you first have testicular cancer? And take us through what happened.
Yeah, so I was diagnosed in 2006. I actually had stage 1 seminoma. The diagnosis was actually a relief, which is kind of unusual for most people. Most people are shocked, but I had felt a lump 7 months earlier and knew it was cancer in my head, but instead of going to the doctor, decided that I would go after this or after that, and I kept delaying for 7 months. And in the process, convinced myself that, I had metastatic disease and was going to die from it. And really lived like I was dying for the 7 months. So a bit unusual, not smart at all. But luckily I'm here today. So
what finally encouraged you to actually go to the doctor? What thought put into, look, I've got to do this?
Yeah, well, I'm a clinical pharmacist by trade. So, as a healthcare professional, I should be smart enough. And honestly, it was, my parents would be devastated if suddenly I died and never went to the doctor. So I'm like, I have to go at some point. And I had a break after a surfing trip and thought, okay, well, before I even left, I said, I'm going to book an appointment for as soon as I get back. And that's what I did.
I suppose it's that's not unique, really, is it? I think a lot of, well, I don't know a lot of men, but I've heard it before. A lot of men say, "Oh, I left it, and it'll go away." I sort of left it a bit, but but I think most men sort of like. I don't think many men actually go, "I'm going to the doctors tomorrow," do they? They sort of, "Oh, it's a lump. I'll see if it goes away." So it's not unique, I don't suppose, but. After that, you decided to set up your own non-profit. In the UK, we call them charities. The America call. What did you call them, charities? Or just non-profit?
Charities too. Yeah.
Okay. Because the word non-profit seems to be bounced around quite a lot now, doesn't it? But obviously, having testicular cancer, you decided to set up the Testicular Cancer Society, which is brilliant. Excuse me. A brilliant non-profit that you run. When did that come about? Was it pretty soon afterwards, or did you decide to? When did it start?
Yeah, we originally started in about a year and a half, 2 years after my diagnosis. Yeah. So there was what was called a race to replace Lance Armstrong, and that kind of got me thinking about stuff. And I wanted to do a fundraiser for him, and it didn't work out. And I had, when I was diagnosed, there used to be people back, actually, like people on MySpace, and that's all you had, and so you would try to find another testicular cancer survivor. You couldn't hardly find anyone. There weren't really a bunch of organizations. The resources you could find were far and in between. And so I kind of thought, well, I don't want to recreate anything. You guys were around. There were the testicularcancer.com forums. There was the TCRC listserv. But I thought, if I could even be kind of the hub of a wheel, right? And people would come here and then we can say, hey, there's a resource, and let's learn about your experience and build other things that aren't available now. So that's really kind of how it came about.
You wanted to be more like what we do, more like, face-to-face and personal with people who diagnose and offer a bit of advice. And obviously get a lot of info out. I remember was it Livestrong? Is that still going, Livestrong? Is it still there?
Yeah, they're still around.
Yeah, because I think I read Lance Armstrong's book when I was going through the first cancer. I sort of not so much live strong, but I wanted to do something locally in the UK. And as you know, it gets quite big pretty quick. But but can you set out Testicular Cancer Society, and what did you find was the hardest thing to do when you were setting up a non-profit? Was it any sort of, because I found that you put an awful lot of work in, and then you sort of, is anyone listening? Is anybody care? It's quite hard, isn't it? So you've gradually built up C Society. It's pretty big across the world. So what are the highlights so far, if you think that a couple of things that make it worth doing?
I mean, the highlight personally for me is just being able to help people, so I'm a bit uniquely positioned as, a healthcare professional and a survivor. So I kind of, I understand both sides of the bed rails. So I can take what a patient says to me, understand what's going on, and then even relate it to a physician and back the opposite way, just from a communication standpoint. I mean, pharmacists are trained, really to be able to communicate like that. Yeah. But to be able to make the connections on the healthcare professional side, so that, if you're a patient in Australia, I can tell you who the top doctors are in Sydney and Melbourne, right, and get you connected there. So that's really been the most rewarding thing. I mean, there's literally been, there's one young man in particular I can remember in Australia who was told, you have metastatic disease, go home, it's time to die. And he finally took the advice and went to one of the experts in Melbourne, had an RPL&D, right, and is still alive and well today. So, yeah, that's huge. I mean, that's literal lives saved. And so that's really the most rewarding thing.
Yeah, Mike, can I ask, as you're a healthcare professional living in the States, now you must see, I try to keep it in the UK, as you know, but you obviously, as a healthcare professional, I can understand things a bit better than me. Can you see what are the big differences between, like, say, the United States and the UK and Australia, for example, when it comes to actual how people get treated? Are there more options, you say, for example, in the United States compared to the UK, if somebody gets a certain sort of stage? I mean, we've seen lately, and you've been involved in it, where some people, like you've said, have said, well, there's not much more we can do. Do you think that's just really, is it the same in the United States? Will the United States keep going, if you get me, if they've got more options compared to, say, the UK?
I mean, it's pretty standard treatments, around the world. There are some subtle differences, just in patterns of use. In the US, we probably do more RPL&Ds, primary up front than done in the UK. There are some certain things in the UK that are done that aren't done in the US. Right. A carboplatin AUC 10 dose for metastatic seminoma, for example, is something we don't do in the US. The UK looks at, carboplatin combined with radiation therapy in some of the centers. We don't do that in the US. Right. When I was diagnosed, the standard for stage 1 seminoma was radiation. And then the other option was active surveillance, which we now know is preferred. There was the option for carboplatin, but it was kind of too investigational in the US at the time. Right. So sometimes each place can be ahead a little bit or behind the other, right, in the thought process, and that's good, right? I mean, you have a disease where the success rate is really, really high. And so it's kind of a double-edged sword. Like, what do you try to increase the survival rate that's already almost perfect, and then fall short and lose lives because you're trying? It can be difficult. I mean, the biggest challenge now, I think, with testicular cancer isn't necessarily the sit in the lab, come up with a new entity, a new drug. It's really doing what we know and doing it according to guidelines. Right. And then really the biggest thing isn't as much the fight for the cure, it's the burden of the cured, right? How can we keep the cure rate high and reduce the long-term effects? And that's one of the biggest challenges.
And have you seen over in the States, Mike, any new sort of projects that are coming through, or anything that you can tell us about?
I mean, probably the biggest thing recently has been the use of RPL&D in early stage 2 seminoma.
Yeah.
It was led by Dr. Danishman out of the University of Southern California. Traditionally, RPL&D hadn't been used in seminoma. It might be used after chemotherapy, but not up front.
Right.
So that's probably the biggest thing recently. One of the problems we've had with testicular cancer is patient recruitment, right? So let's say for a relapse patient, you're not sure, do you go with a standard second-line chemotherapy, or do you go with high-dose chemotherapy with stem cell rescue? And there just aren't enough patients to get into a trial, and the trial is allowed. I mean, now what we're doing, and this is a perfect example, is the Tiger trial looking at this particular question. And, we've teamed up with the US, with centers of excellence in the UK, Europe, and Australia, and all come together to recruit patients. So that's kind of one of the biggest exciting things, is that, we now have global groups that are working to get these patients that are more rare, for lack of a better term, and really try to solve some of the questions that are still out there.
That's quite exciting.
Yeah.
I mean, as you know, my second one, I had seminoma behind the stomach, and I was told no chance of, it's got to be chemo. I've always been told that you can't have seminoma, the lymph nodes out, because they're sticky, and I just, okay, just took it at face value. So I had to go on chemo again. But that's quite exciting that stage 2, maybe I was just a touch too early.
And it's early stage 2, and I mean, there is patient selection. I mean, it needs to be a typical landing zone for the cancer.
All right, okay.
So if you have it show up at a slightly different location, then chemotherapy is probably what your doctor would advise.
But it is exciting.
Yeah.
And I remember when I first started and I got to know a bit. I'm not as medically trained as you, Mike, though, but I know a little bit. But it was always chemo for everything. It was just a chemo. I mean, even just as far back as 2005, chemo. But having had chemo twice, it's not nice. And as you know, Mike, because we've discussed off camera, the long-term side effects, which what I'm starting to really feel now, aren't nice. I mean, yeah, grateful I'm alive again, fine. And then second time, I'm alive still. But I'm sort of turning towards, if we could get rid of this cancer with as less chemo as possible, I'm slowly turning that way, as because I've had it twice with chemo, and you think, have chemo, it works. Have chemo, it works. Look at me. But the fact that they could be doing that, especially seminoma, is which is 50-50. 50-50 in it, non-seminoma and pure seminoma. So that's exciting for me, that somebody could, well, it's early days, but I find that quite exciting. So, let's look forward to that. But, you've been to the UK a few times, mate. You've got to know a few people around here. You came to us. And, did you put a video up once where you were halfway up Snowdon and you look like you were having a heart attack? I think I was about a mile behind you at the time, though.
No, I have done all 3 peaks, so I don't know who you're picking on. I mean, come on now.
Yeah. What do you think? Because of the dawn of the internet, mate. I try and stay in the UK, but obviously you talk to people from all over the world. But the dawn of the internet is made it a very small world, hasn't it, mate? I mean, you must talk to people from, like you said, Australia and America and the UK. So I mean, I've always tried to get those all working together, which we do to a certain extent. Do you think, like, what could you see 10 years from now? Could you see, like, virtual? I've seen a thing where somebody can have an operation virtually, with a doctor in. I mean, you probably don't have to answer this, but I've seen something that a specialist in London, in San Francisco, can operate a machine in London to take the lymph out. That's pretty freaky, isn't it? You didn't know I was going to ask this question. Obviously, it's just popped into my mind. But there's sort of like how far we've come. Do you know what I mean? It's crazy. So what are your goals from now on? You're obviously going to carry on, and have you I know you're really well known around the world. Your charity. What have you got anything in the plans for the future?
Yeah, I mean, the last 2 years is kind of thrown a wrench in a lot of stuff, right, with this ongoing pandemic. But there's still so much more awareness work that needs to be done out there. I mean, there's literally millions and millions and millions of guys that still need to hear the awareness message. If you can catch it early, as we all know, I mean, the burden of the disease is so much lower. There are some still unanswered questions as far as relapse disease and that kind of stuff. We do publications more from a population health perspective, but how can we try to reduce some of these long-term burdens? Things like fear of recurrence, fear of infertility, things like that. So there's still a lot of work between necessarily curing the disease versus curing the soul. Is kind of how I look at it. Really everybody on the big ball that we call Earth would know about testicular cancer.
I mean, as you know, I tend to do more about the emotional side, getting lads through emotionally, and a bit of support. In a smaller country like UK, I suspect it's a bit easier. But I'm going to throw a curveball at you now, Mike, because I ask a few people this, right? And you don't have to answer if you don't want. But what do you think could be the cause of testicular cancer?
I mean, it's hard to say.
Off record. It's probably not wise asking a health specialist, is it really? But we've all got our views.
Yeah, I mean, we know that testis cancer is one of the most heritable cancers that are out there. I mean, we hear more about the hereditability of breast cancer because there's a particular mutation, right? You hear about BRCA2, and with testicular cancer, it's a bunch of them. So there's no real one actionable target. I think it's more hereditary than we know. Now, what causes it to switch on? I don't know. I mean, we've heard a ton of stuff. We hear this drug's withdrawn from the market because it could cause cancer, and how many people have taken, Zantac or ranitidine is one example here in the US that comes across. The numbers are growing, right? They've been growing for decades, but not astronomical, right? Yeah. So, you would think if it was a new product that a bunch of people are taking or exposed to, that it would go up like that, right? And you're not seeing that. Like, if suddenly DVDs, cause cancer, well, when DVDs came out, everybody has DVDs, you'd think the rate would just go straight up. There's a lot of unknowns. And I think that is one of the biggest problems that we face as survivors and caregivers is, why did it happen to me? Unfortunately, right now, we know that this is one of the cancers that likes young, healthy men and don't really care what you do or what your lifestyles, activities, or habits are. It just strikes like lightning.
True, because I've known professional athletes get it, and I've known people who drink beer and drink kebab and eat kebabs like me get it. So, but my theory, I mean, don't have to agree with this. I always thought in my brain that I've got it in my head that, we start as little girls in the womb and eventually we turn into little boys and come out. I've always thought that may be happening a bit later. Testicles aren't right when we're born, and there's something genetically going to happen to them. Because I've read that testicles are getting smaller in Europe, at least. At the birth weight, testicles are getting smaller. Obviously the sperm count is coming down, and I've got it in my head. I don't know why, Mike, but I've read stuff and put two and two together that maybe babies with small birth weight are more prone to testicular cancer, and twins. You see, and one twin is slightly less developed in the testicle area than when they're born. It's common in twins apparently. So that's how I've always. That's what I've got in my head. I might be wrong, but.
Yeah, well, I mean, there is the testicular dysgenesis kind of thought process about it, where it does have to do with the development of testicles It's probably something that you're born predisposed to, and at some point it's activated. Now, what that actual activation is kind of what I was looking at. But yeah, I mean, we know that, there's certain genetic diseases that run a higher risk. It's so across the board that unfortunately there's not a good way to say, hey, if you drive a blue car, you got to look out. It's not that simple to identify those who are at risk.
Yeah. But actually, while you have got your mic, can you just briefly, now we in the UK are lucky enough to have a free health service, whether it be slow or fast, whatever. Now, I hear horror stories, or I've read, or people contacting me in America over the years, not often, but we're about to lose our house in the States. I mean, how does the insurance system work? Briefly, you don't have to go into great detail, but for example, someone in your profession, or let's say like a mechanic, how does the insurance system work if you're diagnosed with testicular cancer in America?
Well, basically, it's like highway robbery.
I'm finished.
Okay, now we're done. It really doesn't
make, but not that brief.
It's difficult, right? So in the US, essentially, so I don't get my insurance through my employer, for example. So and regardless if you do, the employers help out, but it's still the same system. So you have to pay a certain amount of money every month just to get the insurance. Right now, mine's almost $600 a month that I pay just to be able to get health insurance. Now, if anything goes wrong, I have to meet a deductible, which means I have to spend more money to reach that. So in my case, this year, they increased it from $0 to $6,500. So now I have to spend another $6,500 before the health insurance company ever pays a penny for my care. Now, the maximum I can pay per year is $8,500. Then insurance takes care of all of it. But it's a game, right? If I start chemo in December and it goes into January, well, January 1st, I have to start paying that $6,500 back because it resets. Because for some reason, when it comes to health, the end of the year is some magic thing. And then it also works here as access. Yeah, we have freedom to go anywhere we want, but not every place is covered by every insurance plan. I mean, right now I have the worst insurance and coverage for healthcare that I've had in my entire life. And I've carried my insurance plenty of times before. I've had small businesses where I've carried my own insurance. So there's certainly pluses and minuses.
But because you've had, like car insurance, if you have a crash, insurance goes up. Because you've had testicular cancer and you go to your insurance company, would they say, right, we're banging it up more because you're a higher risk?
No, so that's one of the good things that is flushed out. It used to be like that. If you had a history of testicular cancer, no insurance company would give you insurance, or it would be so expensive that you couldn't afford it. We'll give it to you for $3,000 a month. So that was called pre-existing conditions. That's no longer something. They can't charge you anymore for how sick you are. They can't even really know. You can go and say, they don't even ask anymore. There used to also be lifetime limits. So insurance company could say, oh, well, you've hit $100,000 in healthcare in the last 5 years. We don't have to pay anymore. They got rid of that as well.
So is improving in that aspect?
It's getting there. It's slightly different systems, and obviously both have pluses and minuses. Right. I'm in the Facebook group and I see a lot. I got a letter. I don't know who to call or who to talk to. Yeah. Where if in my mind, if something is going awry in the UK, you kind of have to fight the government, right? Where if I'm not getting the right healthcare that I need, well, I could get a whole bunch of people and I could go to the insurance company and petition out front. I could go to the hospital and petition out front. I can go to the government and ask for help, so I don't know. There's pluses and minuses. One of the great things I see in the UK is more centralization of care. You have your dedicated cancer centers, right?
Yeah.
Where
They're only recently, really. They're all going like now, to be honest, Mike. But yeah, carry on. Sorry.
Yeah, well, in the U.S., for example, we have 1,500 hospitals in what's called the National Cancer Database. Out of all those 1,500 hospitals, less than 20 see 20 or more new testicular cancer patients a year. So the vast majority are being treated at different hospitals all around the country that might see one patient every 2 years.
Right.
And so there's really no buildup of expertise in those centers. Unlike the UK, where you have everyone kind of coming into one center in the area. I mean, we have 15 hospitals within 20 miles of me, and every one of them can treat testicular cancer.
Right. Okay. Yeah. That's. I see a lot of posts in America saying that they're traveling quite a way to see a specialist. Yeah, the UK is a lot smaller. I mean, we're about the size of Texas, aren't we? Briefly, mate, quick ones. If say like a mechanic hasn't got health insurance in the United States, can't afford it, and he gets diagnosed with testicular cancer, what would happen?
A lot of the hospitals, because they get money from the federal government to take care of people that are uninsured, they'll get care. It's going to be difficult. There's a lot of red tape to go through. We've called physicians' offices before and kind of pitched a fit or, said, hey, why aren't you treating this young man with a curable neoplasm? There's systems out. I mean, there really are systems out there. So you can sign up for health insurance like I do. And if you don't make a lot of money, the federal government helps you pay those premiums. Right. So there's a commercial on TV, the same place I get my insurance. They say that 4 out of 5 people that get insurance there spend less than $50 a month on their insurance.
Right.
That's probably because I'm paying $600 and everybody else is using my $600. But, and if you don't meet certain income requirements, then we have, what's called Medicaid, essentially, which is different state programs that take care of individuals that don't have any income or, barely any income. There's solutions out there. It's more difficult, obviously.
But they're not going to, this is going to sound pretty morbid, but they're not left to die and just said, sorry, you're not insured. They will get some sort of care, but like you say, it's difficult. But as most of the country got health insurance.
Yeah, I mean, we still have, a significant amount of uninsured, and I think those numbers are hard to find too. It's usually more, young individuals as well. And I think the thing is it's based on age, right? So, when you're 60 years old, you're going to be paying $800 or $1,000 a month for your insurance, and that's going to be tough for people to have lived paycheck for paycheck their entire life. Out of all the years I've been doing this, I only know of one patient that has died because they didn't have access to care. Right. Now, I'm sure that there's more out there, but this individual, the sister actually ended up calling me, and care had been refused 6 months earlier. So it took them 6 months to call me, but I was able to look at a local cancer center. I could see that someone that sat on their board was a urologist. I was able to message a urologist and say, I know this is kind of out of protocol, but I don't want to see this young man die. What can we do? And they got him right in, but unfortunately, his disease was too progressed and he passed away. Is that reasonable? No. If you don't know how to pull the strings, no. But that's why we do what we do, right? I can go to the hospital. I can say, okay, the hospital's not even helping me, not even the head of the hospital, but they have a board of directors, and the board of directors, there's someone on there that I can reach out to and say, even if you have to threaten to run to the press, I mean, whatever we need to do to get someone care, we'll do.
Yeah, I see that. But it just, it's wrong, isn't it? But you're lucky, I could contact. I mean, I'm pretty well known in the UK setting this up, and I like to think I'm a little bit respected by the people I help. We've we give advice to and the talks I do, but there's somewhat slight snobbery in the UK that if I contacted being from a working class city of Liverpool and a truck driver, that if I contacted an oncologist and said, I don't think what you're doing is right, then who do you think you're talking to, sort of? And there's a risk of, you know, he's dangerous. Keep away from that filly, you know, and try and block you. I don't know if it's the same in America. I know you're medically trained, mate, but do you think somebody might go, oh, keep away from that Mick Craycraft because he's interfering a bit? Do you think there's a risk there?
No, I think it's the way you position it, right? I mean, yeah, I've also worked in hospitals for
Oh, yeah, okay.
25 years, you know,
Yeah.
so, you know, I know how to talk to people, you know, in the right way, I suppose. You know, I had a case a couple of years ago where it was a Leydig cell tumor, right? So 90% of those are not really, don't have metastatic potential, but there's some details in the pathology report. So the guy sends me his pathology report and I look through it and I say, well, it didn't mention this, this, and this. And if it doesn't mention it, it means that it wasn't seen, is how they chart. And so about an hour later, I got a call from the pathologist, which you don't get calls or talk to pathologists. Like, I don't know how this patient did, but evidently the patient got a hold of the pathologist and told him stuff was missing from his report. So didn't understand what I was saying. The pathologist calls yelling at me, what do you want in my report? I'm like, well, hold on, it's a miscommunication. Here's what I was doing. And he's like, oh, so you were helping patients understand their pathology report? You do that? Totally turned around, you know. So I don't think so. I mean, we're not calling and saying, you know, what you're doing wrong. We're calling and say, you know, why can't this patient get in? What, you know, what's the medications we use are 40 years old. You know, it's just made up numbers too, right? So they'll say it's $3,000 a day to go into the chemo center to get your infusion. Well, why is it $3,000 a day? You know, you're not paying the nurse $3,000 a day to help that patient.
Yeah.
Like, these numbers are all just made up.
Sure.
You take a drug that's $1 and you charge $5 for it. So let's get real. You know, what we're talking here is a couple of $1,000. Is it worth a couple of $1,000, you know, that you might have to eat to keep a good name or to save a life? And, you know, it would be different if we're talking a brand new treatment that's $120,000. There's no way that we'd be able to get things accomplished.
Yeah, sure. Yeah.
We're just fortunate with testis cancer that's not the case.
Right. Because luckily the cure, don't like saying the word, luckily the treatment for testicular cancer was defined by Professor Einhorn quite a while ago before people could jump in on it. So it was already out in the system, wasn't it? Where, well, you can't charge for that and you can't charge for this. But I think it's brilliant that you actually go out and get people's back, Mike. And that's great. It's different in the UK. It was certainly different what I do, as you know. I sort of like befriend people. I know you do as well. But I think that's great that you stick up for people when needed. And because, you know, I always think, you know, when we first started, Mike's in the US and Phil's in the UK. There's a new one in Denmark started. I like to think me and you maybe sort of people think that's a good idea what they've done, if you get me. So maybe, you know, what we're doing, I mean, there's still not much, is there? I mean, the America's got you, the UK's got me, Denmark is starting up. There is one only just started in Germany. There's one only just started in Italy. There's one starting in Spain. There's one starting in I forgot, Italy. So we're slowly getting there, aren't we? I think more, and support as well, emotional support, friendship is, I think, just as important, as you know. But I think it's when I first had it, if I had someone to talk to, I did have someone. Remember Scott? A bit later on, Scott Joy and your forum that you run now. But there wasn't really. You could ring someone up, or I'm feeling really low today. Oh, that's normal. Come on, you know, it's all. And I get a lot of calls saying I found a lump. Unfortunately, you know, you just say, well, I can't tell you what a lump is. I can tell you what it might be. You know, does it move about unless it's stuck to the wall, or you need to get them all checked. You know, I do that. But emotional support, I think, is important, and I know you do it, and I know we do it, but like I said, I thought you were the USA with the UK, but it's a small world, isn't it? We talk to people from all over the world, so yeah. But yeah, we're going to finish now. But interesting, I've learned something every time I speak to Mike. I learn something, right? I also learn that he has a different hairstyle every time I see him. But if you want to visit Mike's site and say hello, testicularcancersociety.com, isn't it? Is it org?
.org.
Sorry, testicularcancersociety.org. And Mike's in America, but you know, if there's technical questions, what he's really good at, he sometimes jumps in our forum as well, and answers a few questions. He's a great guy. I'm proud to call him a friend, even though I fall out with everybody. The only person I've ever really fallen out with, Mike. And he has had it. Yeah, you have had a curry on my couch, haven't you? I don't know, that was years ago.
Yeah, I actually I took a poo in your loo. That's my claim to fame. They'll be like, do you know Philly? And I'm like, yeah, I took a poo in his loo at his house.
And you know what? We haven't flushed it. We haven't flushed it ever since. It's still there.
People ask me for my autograph. They're like, really?
So that's funny. But Mike, I want to thank you. And I do admire you a lot, to be honest. So I don't say that to a lot of people. But you've stayed my friend throughout and kept in touch with me. When my second cancer came up, you drop a message, how you doing? So I thank you very much. But yeah, testicularcancersociety.org. Go on, sorry.
Thank you for your kind words, and I mean, keep up what you're doing. I mean, you know, you're a legend and an inspiration back. So, you know, you've been here before I was, you know, and it's rough. And you talk about, you know, new things starting up, and over the years, I've seen a lot of new things start up. You know, someone gets diagnosed, and then, you know, 3-4 years later, they're back to living life, which is great. And, you know, what they're doing in the community kind of dwindles off, and that's awesome. I mean, our greatest thing would be you have testicular cancer, and a couple of weeks later, you go on with life completely normal. That would be awesome. But it's not easy. I mean, to keep in the game as long as you've been, as long as I've been, you know, it's needed. It's needed. So keep it up. You know, it's a hard grind, but you're doing it.
It is too easy, Mike, to put a website up without check your test scores and then 50 pages about how to donate, and that's easy. I mean, you both don't do that, do we? So, but I'll let you go, Mike, because I know it's your Sunday and you've been at work all night. So I want to thank you for talking to me. I'm not going to play this back to you. I'm going to put it straight online, whether you like it or not. But Mike Craycraft, testicular cancer. Sorry. By the way, guys, I've got an ear infection. Why I've got a hat on. So it's so testicularcancersociety.org. Brilliant website, brilliant guy, and he'll have you back. And I'm slow being from what I do. I think in the background, having Mike behind us, keeping a close eye on the new developments and sticking up for people, and in the future we'll benefit from it. So thanks, Mike.
Thanks, buddy. I appreciate it. Have a great one, mate.
Take care of yourself now.
Bye.
See you, Mike. Bye. No, I won't.